addition to what I told you I already am, I'm also a bariatric surgeon, and I have been one since 91, kind of the same year as the NIH guidelines, it seems. And if I think back to where I started, we were doing essentially only 2 operations, both open, the bypass and vertical band gastroplasty. And relative to where we are today, we had relatively high complication rates, much higher mortality rate, a very high recidivism rate. And boy, you really didn't want to tell people you were a bariatric surgeon because we were not viewed with the same respect that one would view we did. And I remember being on call for general surgery and going down to the emergency room for a woman with appendicitis who said, I really don't know that I want you to do my surgery. I've looked it up. You're a stomach stapler. Well, I hope many of you in the field remember those days because they're long gone. What have we accomplished since then as an organization? We achieved meaningful and sustainable weight loss in the procedures we're performing. Our procedures improve and even cure most of the obesity-related comorbid conditions. Let's see a vascular operation that can do that. We improve life expectancy. We improve quality of life. And we do something that I'm not even certain is a good thing, but nobody else can claim it. We can demonstrate a return on investment in what we do. We save money to the healthcare system. Everybody's program can demonstrate data like Phil Showers a few years ago. If you look at all these comorbid conditions and you add up the percent improved and the percent resolved, we're 90%. And that's a track record that I don't see any other procedure or treatment in any other field in medicine that can go up there and show a slide like this. And as Harvey Sugarman put it so well a few years ago, there is no other modality in all of medicine that can cure so many conditions with that one intervention. Be proud of that. We earned it. And as Doug Hess said, if you want to be a bariatric surgeon, it has to be in your blood. We're now a subspecialty, and we've earned that too. We're not just general surgeons that dabble in stomach stapling. And as Walter put it best, my daddy's a doctor and he treats diabetes. My daddy's a surgeon and a member of ASMBS, and he cures it. And if you look in the literature for mortality data, comparing groups that have had surgery versus matched cohorts of patients that were spared the risk of surgery, every single paper in the literature has the same message: reduction in death with surgery. There wasn't a single paper that I could find that said the opposite, that you're putting your life at risk if you have surgery. And here's the return on investment. This was a paper by Pierre Crémeau, an epidemiologist who did analysis of 5 million covered lives from a database held by the insurance industry. And the panel all the way on the right shows that laparoscopic gastric bypass has a return on investment in 25 months, and open gastric bypass is 49 months. And we're innovative. We don't sit on our laurels. We're forever trying to get better. We're always out there trying to come up with yet a better operation, a safer operation. And we have people in this field, such as Michel Gagne and Whitgrove and Dr. Hess and Marceau, who are brilliant in saying, let's try better. And the future is even going further, with the work being done in neuromodulation, endoscopic surgery, endoscopic sleeves, pushing the envelope with sills and notes, and this whole concept of targeting diseases and calling ourselves a metabolic society. And this is unprecedented. What other society in medicine, what other group of surgeons has taken such a formal approach, not to police itself, but to set a very high standard for all who practice, not tolerating practice that falls below that bar? And look at the results. 30-day mortality, 0.1%. That's gallbladder surgery range for operations that have always been considered complex on patients that will always been considered complex. That's a tribute to the people in our society. Walter Porres, Ken Champion, Alan Whitgrove, and the others who sat there one day and said, we need to do better. So, terrific. I've been a bariatric surgeon for 18 years, and we've gone literally from the Stone Age to the Jet Age. But I've got a little warning for you. Are we becoming the victims of our own success in some ways? And I think we may be. And I want to cover two topics, and this is my charge for you to continue these fights. Like Neil Hutcher, I have this burning desire to never let a patient get denied insurance coverage because of an unfair, arbitrary, or stupid rule because they want to save money. We have to fight for our patients. Access to care is a problem because now that we're on the radar scope and now that the number of cases have increased, the insurance industry has taken note. They're not going to cut care for breast cancer or HIV because they're too politically hot, but they can pick on our patients because they know politically they're impotent. And that's part of the reason that less than 1% of potential patients out there are getting the therapy that we know works, we know they need, and we know is cost effective. And what are these obstacles to care? Well, all of you could probably recite them as well as I. Eliminating coverage altogether or making coverage there with an expensive rider. The mandatory supervised weight loss program from 6 to 12 months, sometimes not even involving a visit to your clinic, but a telephonic program where you speak to a coach once a month. The 5-year history of morbid obesity, and during which if one of those years your BMI fell to 39, you're disqualified. IQ testing. And what do they say? Well, we've all spoken to them. We've had these frustrating conversations. Well, there's not a lot of evidence-based medicine to support surgery. We're concerned about patient safety. So many patients are dying of these operations. Maybe they ought to read the paper DeMaria is publishing. The informed consent process, that if you make a patient do 6 months in your program, their informed consent will be magically better. What do I say in my experience with dealing with these people? They're saving money at the expense of our patients, and that's not acceptable. What can we do? We fight on. We fight every day. We don't accept defeat. We do everything in our power. We use all the resources we have. We use all of the connections we have, our partnerships with societies, with industry, things that Phil Shower has been talking about for years, getting better relationships with TOS and the ADA, SAGES, ACS, so that we're all fighting together. As we learned from Roger Kizin and his group, stay on message, take the high road, don't scream at them and yell and threaten, but do it the right way. And I went through this a couple of years ago with my colleagues in Massachusetts, and I just want to spend a few minutes explaining to you what we were up against. In Massachusetts, there were 3 major health insurance companies, Blue Cross Blue Shield, Harvard Pilgrim, and Tufts Health Plan. Tufts Health Plan is not associated with Tufts Medical School or Tufts University School of Medicine or Tufts Medical Center. And they decided out of the blue in December 2 years ago that they were going to eliminate all coverage for BMI less than 40, regardless of the comorbids or how worthy the patient was otherwise. They were going to limit coverage for BMI 40 to 50 to one operation, their operation, the one they chose, the band. And they were going to mandate that all candidates have to do a 12-month telephonic program called I Can Change to even be considered for surgery. What was their goal? They were concerned about the rapid growth of bariatric surgery, and they wanted to put a stop to it. Well, from my own research, talking to people, contacts, I found out a few things about what was going on at that time. I was told there was a money issue. They had lost some membership. They were a little bit behind. They were threatening layoffs. The president and CEO is not a physician. He's a lawyer. The chief medical officer was a physician, although I don't believe he is one anymore. And in a few years prior to all this, he was at a meeting where he gave a talk, and the last bullet in his conclusion was obesity surgery must be minimized. And the talk had nothing to do with this. And we met with them, and what did they say? Well, you know, there's unchecked growth. It's exploding. Patients are being seen by a surgeon and being operated on 10 minutes later. There's no literature to support body mass index 35 to 40, regardless of diabetes and high blood pressure and sleep apnea. And the band was safe and therefore was the thing to be used because it was cost effective in their analysis.